Dear student, I am Dr. 𝗓𝐵𝐻𝐿𝐲, Professor of Biochemistry. So in this video, I will be explaining you all about vitamin A. Vitamin A, collectively, we refer it to retinol, that is an alcohol form of vitamin A, retinaldehyde and retinoic acid. So retinol, retinal, retinoic acid, these are the terms for vitamin A. In a strictest term, that vitamin A is actually refers to alcohol form of vitamin A, that is retinol. All three forms of vitamin A, whether it is retinol, retinal, retinoic acid, all of them, they will have a biological activity. Now, retinoids are all forms of vitamin A, that includes even the synthetic form of vitamin A. So, the retinoid term is actually, it includes even the synthetic vitamin A molecules. So, collectively, whether it is a natural form or the synthetic form, so we refer that as retinoids. Now, let's look at the structure of each one of them. So, alcohol form of vitamin A. So, it has got alcohol group in the hydrocarbon chain there. That is why it is called as OL, retinol. And then retinaldehyde or retinal, it has got aldehyde group there, and retinoic acid, it has got acidic group COOH, and beta carotene has got pro-vitamin A activity. So in fact, beta carotene, it has got two retinol molecules attached together. Okay, so these are structures of different forms of vitamin A, that includes retinol, retinal, retinoic acid and beta carotene. Now, retinol, it is found in animal tissues as retinyl esters with the long chain fatty acids attached. Retinaldehyde, it is obtained upon oxidation of retinol. Basically, retinol, when it undergoes oxidation, it will be converted into retinaldehyde, and retinaldehyde furthermore, when it undergoes oxidation, it will be converted into retinoic acid. Of course, there is a need for enzymes to oxidize these molecules. Alcohol form of vitamin A oxidized into aldehyde form further oxidized into alcohol form. And the beta carotene is abundantly present in foods coming from plant source, and in the intestine, beta carotene, it will yield two molecules of retinaldehyde, though not as a sufficient source of retinaldehyde, but beta carotene, it is going to provide two retinaldehyde molecules in the intestine. Coming to how this beta carotene is digested in the intestine and how it is going to be converted into a retinaldehyde molecule. So, food coming from plant source. So, it is going to contain a beta carotene molecule, and this beta carotene molecule need to be digested in the intestine. How that happens? There is an enzyme called beta carotene dioxygenase enzyme, and this beta carotene dioxygenase, it is going to cleave at 15 carbon of hydrocarbon chain there. So, sometimes this is referred as 15-15 dioxygenase enzyme, and it is going to release a retinaldehyde, which is an all-trans form of vitamin A, retinaldehyde. And this particular enzyme, it needs a molecular oxygen, and also this reaction is facilitated by the presence of bile salts. So, beta carotene dioxygenase enzyme, which is a monooxygenase system of enzyme, which is activated in the presence of bile salts, is going to break a beta carotene into two retinaldehyde molecule, and that's what happens to beta carotene in the intestine. So, what will happen to the retinaldehyde? Now, the retinaldehyde, depending on the tissue type, like wherever it is taken up by the tissue, retinaldehyde can be oxidized into retinoic acid, and retinoic acid, depending on the tissue type, it has got its function. We are going to see how exactly that happens, what exactly is the function of retinoic acid. Or retinaldehyde can be reduced into retinol, reduction of retinaldehyde into retinol, and that will be done by retinol reductase enzyme as it is shown here. So, retinol reductase enzyme is going to convert retinaldehyde into retinol alcohol form of vitamin A, and that needs NADH plus, which is oxidized into NAD plus molecule. And also with retinol isomerase enzyme, so retinaldehyde, which is in all trans form, it can be converted into 11-cis form of retinaldehyde. All trans retinaldehyde can be converted into 11-cis retinaldehyde by retinal isomerase enzyme. Now, once you get 11-cis retinaldehyde, this 11-cis retinaldehyde, it can be involved in formation of rhodopsin. Rhodopsin is a visual purple present in the rod cells of the retina. So, what happens here is 11-cis retinaldehyde is going to combine with a protein called opsin to make a rhodopsin. And rhodopsin, whenever dim light falls onto the rhodopsin on the rod cells of the retina, so rhodopsin will be bleached into all trans retinaldehyde and vision process is made possible. Now let's move on to see dietary sources of vitamin A. So we have a plant source for vitamin A, that is beta carotene, and we get it from colored fruits fruits and vegetables like carrot, mango, papaya, green vegetables are the good sources of beta carotene. Whereas the animal source is going to contain a retinyl ester. Make sure to know that vitamin A coming from the animal source, it is present in the form of retinyl ester, whereas coming from the plant source, it is present as beta carotene. So the good animal sources for vitamin A, it is liver, egg yolk, fish liver oil, milk and milk products. Now, absorption of beta carotene, it is quite different than the absorption of retinol. Because beta carotene, first it has to be broken down into individual retinaldehyde molecule, and that will be done by 15-15 dioxygenase enzyme to release 2 molecules of retinaldehyde. In fact, there will be release of 2 retinaldehyde molecules, and these 2 retinaldehyde molecules furthermore can be reduced into retinol by dehydrogenase enzyme, of course, where NADH plus is converted into NAD plus molecule and alcohol form of vitamin A is released here. And this alcohol form of vitamin A can be converted into retinyl esters in the enterocytes, and then it will be loaded onto ApoB48 in the intestine to make chylomicron. That's how beta carotenes coming from the plant source in the intestine will be ultimately converted into 2 molecules of retinol, and these 2 molecules of retinol further will be converted into retinyl esters and will be loaded into onto the ApoB48 protein to become part of chylomicron. So ultimately it will become part of chylomicron and carried to the liver. Now, in the absorption of beta carotene, so the receptor that is helping in the absorption of beta carotene over the enterocyte membrane is the scavenger receptor B1. Make sure you remember the name of the receptor that helps in the absorption of beta carotene over the enterocyte membrane. It is scavenger receptor B1. It is absorbing that whole beta carotene molecule inside the enterocyte, and in the enterocyte the 15-15 dioxygenase enzyme. It is basically beta carotene monooxygenase system of enzyme. It is going to break that beta carotene into 2 individual retinaldehyde molecules, and these individual retinaldehyde molecules furthermore they are converted into retinol alcohol form, and then they will be converted into retinyl esters, and then they will be loaded onto ApoB48 to become chylomicron. So the absorption of beta carotene from the intestinal lumen through its scavenger receptor B1, it is a less efficient process, and beta carotene is responsible for the orange color of the carrot and papaya. So these colored fruits and vegetables, partly it is because of the beta carotene that is present in that. So let's look at the picture here, figure, which will show the absorption of beta carotene as opposed to the absorption of retinyl esters. Because we know beta carotene is coming from the plant source and retinyl ester is coming from the animal source. Okay, so beta carotene, it is absorbed into the enterocyte with this SRB1 transporter. Remember that SRB1 transporter is the one that helps in the absorption of beta carotene. Entire molecule is absorbed. All the beta carotene is a complex molecule. Once it is inside, this beta carotene, it splits into 2 retinaldehyde molecules, and that is done by a beta carotene monooxygenase enzyme, BCMO1 here, and where molecular oxygen is necessary, and bile salts enhances this reaction. Now this retinaldehyde will be converted into retinol. 2 retinaldehyde molecules can be reduced into 2 retinol molecules, alcohol form, done by retinol reductase enzyme. And now 2 retinol molecules can undergo esterification, where fatty acid is added on to retinol to become retinyl ester, and that is done by lecithin retinol acyl transferase, LRAT enzyme. LRAT is lecithin retinol acyl transferase enzyme. Now that's how retinyl esters are made, coming from the beta carotene. So basically we will have 2 retinyl esters. Now this retinyl ester can be loaded onto APO B48 proteins to become part of chylomicrons. Now let's look at retinyl esters on the other side of this particular figure. So which is coming from the animal source. So retinyl ester in the intestinal lumen is converted into retinol, alcohol form of vitamin A. So retinyl ester is converted into retinol by a pancreatic hydrolase enzyme, pancreatic carboxylic acid ester hydrolase enzyme. Basically it's a pancreatic enzyme which is going to remove fatty acid from the retinyl ester, release the fatty acid, and the retinol alcohol form is made, and that alcohol form of vitamin A entering into the cell enterocytes, and in the enterocyte LRAT enzyme, lecithin retinol acyl transferase enzyme, it is going to add a fatty acid to this retinol and make it as retinyl ester, and once it is there in the form of retinyl ester, this retinyl ester will be loaded onto APO B48 protein to make chylomicrons, and chylomicrons are secreted into lymphatics, and from lymphatics it will find its way into systemic circulation, and from the systemic circulation it will go to the liver, and that's how vitamin A will travel from the intestinal lumen all the way to the liver, and it will be stored in the liver until it is transported out of the liver. Now absorption of retinyl esters, which I have explained you. So the pancreatic carboxylic ester hydrolase enzyme is involved in that, and then this retinyl ester which is converted into free retinol, and further in the intestine it will undergo reesterification and it will become part of chylomicrons. So we have seen that already. Coming to a disorder here called keratoninemia or keratinoderma. What is this keratoninemia or keratinoderma? So this keratonemia disease, it results from deposition of beta carotene, which is basically it is going to color the skin yellowish discoloration of the skin, which is first observed over nose, nasolabial folds, palms of the hands, soles of the feet, and then eventually you can see that yellowish discoloration of the skin all over the body. However, the sclera, that is the white part of the eye, and also the mucous membrane, they are spared. They are not yellowish colored, and this will distinguish keratoderma or keratonemia or keratinoderma from jaundice, because in jaundice we are going to see the yellowish discoloration of the sclera and also yellowish discoloration of the palmar creases and all that. Mucous membrane, yellowish discoloration of the sclera, yellowish discoloration of the mucous membrane can be seen in jaundice, whereas in keratinoderma or keratonemia, you generally don't see yellowish discoloration of the sclera or the mucous membrane. Of course, you see yellowish discoloration in all other body parts, and that is how we can distinguish jaundice from keratonemia. So keratonemia is particularly common among infants and toddlers who eat large amount of pureed vegetables, particularly pureed vegetables prepared from carrots and sweet potatoes. Other less common causes for keratonemia can be uncontrolled diabetes mellitus, hypothyroidism, anorexia nervosa, hepatorenal diseases, where there is a decrease in the conversion of beta carotene into retinol. And this beta carotenemia is a benign condition. Elimination of keratin-rich foods results in gradual disappearance of yellowish discoloration. Okay, so that's what is the treatment for keratinoemia. Alright, so now let me explain you transport and storage of vitamin A using this particular figure. So where we can learn everything about vitamin A, especially in relation to how exactly vitamin A is coming from the plant source, animal source, how it is digested, how it is absorbed, how it is transported to the liver, and from the liver how it is transported to all other organs. Let's begin to that. So from the diet, so vitamin A, whether it is coming from the plant source as beta carotene, or if it is coming from the animal source, it is retinyl ester. So let's take a beta carotene first. So beta carotene enters into the enterocyte through SRB1 receptor, and once it is getting inside the enterocyte, the beta carotene, it will be broken down into two retinaldehyde molecules done by 15-15 dioxygenase, also called as a beta carotene monooxygenase enzyme. Now this two retinaldehyde molecules will be converted into two retinol molecules by retinol reductase enzyme, and these two retinol molecules further esterified in the endoplasmic reticulum to become retinyl esters, and this happens in the smooth endoplasmic reticulum, and that is what that's how beta carotene is handled coming from the plant source. Coming to the animal source of vitamin A, which is coming in as retinyl esters, and this retinyl ester inside in the enterocyte in the lumen of the intestine, so it is separated as fatty acid and retinol. So this is done by pancreatic esterase enzymes, and the retinol is taken up by the enterocytes, and once it is inside, retinol is esterified into retinyl ester in the smooth endoplasmic reticulum. Now we have retinyl ester present in the endoplasmic reticulum, smooth endoplasmic reticulum, and these retinyl esters will be loaded on to ApoB48 protein to make chylomicrons, and chylomicrons are initially released into the lymphatics, and from there they go into the systemic circulation, and chylomicrons will be metabolized in the circulation as chylomicron remnant. Only the triglyceride content in the chylomicron is degraded. Rest of the molecules will be same in the chylomicron remnant, and they will be offloaded in the liver. So our molecule of interest here is vitamin A, which is released in the liver, and it is released as all-trans retinol, and further it will be converted into retinyl ester, and it will be stored in the liver, especially in the perisinusoidal ito cells, or the ito cells. And whenever there is a need for vitamin A, so vitamin A is released as retinol, and this retinol will bind with the retinol binding protein, which is synthesized and secreted by the liver, and the retinol binding protein retinol complex is taken to target tissues or target cells. So the target cells will recognize retinol binding protein and will allow this entire complex to enter in, and that's how vitamin A enters into the target cell. Now let's look at the target cell, that is retina here, which is where the vision is made possible. So inside the retina we have vitamin A as all-trans retinol, which is converted into all-trans retinal aldehyde form, and this all-trans retinal is converted into 11-cis retinal, that is 11-cis retinaldehyde, which will combine with opsin to make rhodopsin, and whenever the dim light falls onto the rhodopsin, there will be bleaching process, and where opsin is separated and all-trans retinaldehyde is released, and this all-trans retinaldehyde again it undergoes similar changes, and this is how vitamin A participates in the vision process in the retina. We are going to go into details of this in the later slides. Now let's look at epithelial cells on this side. Retinol released into the blood, retinol binding to the retinol binding protein, taken up by the epithelial cells, and alcohol form of vitamin A is converted into acidic form retinoic acid, and retinoic acid acts as a steroid hormone. It enters into the cytoplasm, bind to the nuclear receptors, and in the nuclear receptor they are going to cause gene activation, and gene activation releasing mRNA, and mRNA changing making a specific protein, and that causes cell differentiation process. And this is how vitamin A is digested, absorbed, transported to the liver, and from the liver it is transported to all other tissues. Now, let's move on to see what is the function of vitamin A. Vitamin A, it is involved in a vision process. The retinaldehyde form of vitamin A, retinal form of vitamin A is involved in the vision process. Retinoic acid form of vitamin A is involved in the growth and cell differentiation. Retinal, alcohol form of vitamin A, is necessary for reproductive system, and carotenoids has got antioxidant role. So make sure you remember all these functions of vitamin A. One more time, aldehyde form is involved in the vision process. Retinoic acid form is involved in cell growth and differentiation. Alcohol form is involved in reproductive system, and carotenoids have got antioxidant role. Now let's look at the role of vitamin A in vision process. Now, both rod cells and cone cells present in the retina contain a photoreceptor pigment in their membrane. And this photosensitive compound, that is photoreceptors of most of the mammalian eyes, is a complex of protein and an aldehyde form of vitamin A. And the aldehyde form of vitamin A specifically that is present in a rod cell is 11-cis retinaldehyde, which will combine with opsin to make a rhodopsin, and rhodopsin is a visual purple, and this is the rhodopsin that is helping in the dim vision. Dim vision is made possible because of sufficient formation of rhodopsin. Let's see how exactly this dim vision is made possible in the rod cells of the retina, and this can be understood by a Wald's visual cycle. Let me write it down here. It is Wald's visual cycle. You got to remember this simple cycle here, Wald's visual cycle. So what actually happens in the Wald's visual cycle is, when a low intensity or a dim light wavelength around 500 nanometer, make sure remember that 500 nanometer wavelength, this is the dim light that is falling on to the rod cells. So at that time what happens, rhodopsin will undergo a series of photoisomerization into unstable intermediates. So the photoisomerization of rhodopsin will lead to a series of unstable intermediates in the following sequence. That is, a rhodopsin will be converted into batho-rhodopsin. Batho-rhodopsin will be converted into lumi-rhodopsin. Lumi-rhodopsin will be converted into meta-rhodopsin. Meta-rhodopsin is converted into that is meta-rhodopsin 1. Meta-rhodopsin 1 is converted into meta-rhodopsin 2, and that meta-rhodopsin 2 is further breaks into all-trans retinaldehyde plus opsin molecule. Okay, this is what happens. This is the series of photoisomerization in the rhodopsin molecule. I am going to repeat one more time how exactly the rhodopsin is undergoing a series of photoisomerization process here. So the series of photoisomerization is rhodopsin is converted into batho-rhodopsin, that is batho-rhodopsin. Batho-rhodopsin is converted into lumi-rhodopsin. Lumi-rhodopsin is converted into meta-rhodopsin 1. Meta-rhodopsin number 1, and meta-rhodopsin number 1 is further converted into meta-rhodopsin number 2, and then meta-rhodopsin number 2 will be converted into all-trans retinaldehyde and opsin will be released, and that's what is the Waltz visual cycle here. Now all trans retinaldehyde will be converted back into 11-cis retinaldehyde, and that will combine with opsin later to reform the rhodopsin. So all trans retinaldehyde combining with opsin to make rhodopsin. That completes the Waltz visual cycle. Now out of all these photoisomerized unstable intermediates, one thing that is the most active form of rhodopsin, it is the meta-rhodopsin 2, and this meta-rhodopsin 2 is the one that initiates the vision process that is possible under dim light. Okay, so now that's what is I was saying here. So the meta-rhodopsin 2 in the Waltz visual cycle is an activated photo-excited conformation, and it is also referred as active rhodopsin. So meta-rhodopsin 2 is referred as active rhodopsin. Make sure you remember that. Active rhodopsin is meta-rhodopsin number 2. It is a photo-excited conformation. This photo-excited conformation, it is going to activate a G protein which is called as transducin, and this G protein activation, it basically mediates vision made possible. Okay, so that's what is here. So one of the point that I would like you to make sure to understand and remember is the photo-excited conformation in the Waltz visual cycle is the meta-rhodopsin 2. Coming to mechanism of vision process, let's understand this particular figure here. So it is important for you to understand the mechanism of vision process, how exactly under dim light around like 500 nanometer wavelength, how exactly vision is made possible. So let's start from point number 1 here. So light stimulates rhodopsin and the activation of transducin. So the rhodopsin, that is meta-rhodopsin 2, that's the active rhodopsin, is going to go and interact with the G protein coupled coupled protein, that is a transducin. And activation of transducin, it leads to separation of G protein which contains alpha, beta and gamma subunit. So alpha subunit is separated from beta gamma when there is a replacement of GDP with GTP. Now the GTP bound alpha subunit, it is going to go and activate cyclic GMP phosphodiesterase enzyme, and this cyclic GMP phosphodiesterase enzyme, furthermore what it does, it is going to convert a cyclic GMP into a just GMP molecule, and that means there will be decrease in the concentration of cyclic GMP. Now note that the cyclic GMP concentration in the rod cells is important because it is going to keep sodium channel in open configuration. Now when there is a drop in the cyclic GMP levels, so the sodium channel is going to be closed. That means sodium influx into the rod cells will be decreased. So that means sodium levels in the rod cells will decrease, and when there is a decrease in the sodium levels in the rod cells, that leads to hyperpolarization of the rod cells. And also note that, see, the sodium efflux is continuously going on, only the sodium influx is decreased. That means positive charges within the rod cell, inside the rod cell, basically the cytoplasmic side, it will be decreased. And because of this, there will be hyperpolarization, and that hyperpolarization will close the calcium channel also. So when the calcium channel is closed, so there will be decrease in the release of glutamate, because glutamate is generally released upon depolarization of the membrane, where calcium is getting in, and increase in the intracellular calcium normally releases glutamate into bipolar junction from the rod cells into the bipolar cells in the junction where the optic neurotransmission has to go on. So the glutamate is continuously released because our rod cells are under normal conditions, rod cells are always partially depolarized. See, the membrane potential of rod cell is minus 30 millivolt compared to minus 70 millivolts of all other cells. So whenever there is a decrease in the calcium levels, decrease in the sodium levels, so the positive charges are decreased, so that leads to hyperpolarization of the rod cell membrane, where the minus 30 millivolt will be increased to minus 35 millivolt, and because of the hyperpolarization, because of the lower levels of calcium within the rod cell cytoplasm, so the release of glutamate into the bipolar junction will be decreased, and that means when the release of glutamate in the bipolar cells are decreased, normally the glutamate will have an inhibitory effect on the bipolar cells. So now when there is a decrease in the release of glutamate into the bipolar cells, that inhibitory effect is now not there. That means, so the signal can pass from the rod cells to the bipolar cells and then into the optic nerve and to the optic center, and the vision made possible. And this is what happens. These are the molecular events. How exactly vision is made possible whenever a dim light or a low intensity light falls onto the rhodopsin. I am going to explain one more time. When the low light falls onto the rhodopsin, there will be bleaching of the rhodopsin, where photoisomerization will lead to series of photo unstable intermediates. One of the important unstable photo intermediate coming from the rhodopsin is the meta-rhodopsin 2, which is referred as active rhodopsin, and this meta-rhodopsin 2 is going to interact with the transducin, which is a G protein coupled protein. So when that happens, so alpha subunit is separated from beta gamma, where GTP bound alpha subunit is going to activate cyclic GMP phosphodiesterase, and that enzyme is going to convert cyclic GMP into just GMP, and that closes the sodium channel, and the sodium channel closes means sodium levels in the cytoplasm decreases. That causes hyperpolarization of the membrane and close the calcium channel. When the calcium channel closes, so glutamate release into the bipolar junction decreases, and the glutamate, normally it is a inhibitory neurotransmitter here. Now there is a decrease in the glutamate. That means inhibition is not there, so neuronal signaling can go on from the rod cells to the bipolar cells and all the way to optic center, and that's how vision is made possible in the dim light. Now let's move on to see what are the other functions of vitamin A in our body. Vitamin A, it is helpful in the regulation of gene expression. So the type of vitamin A that is helpful in the regulation of gene expression is the retinoic acid. So retinoic acid, it acts as a steroid hormone. It is going to go and bind with a specific nuclear receptors called RAR and RXR receptor. This RAR and RXR receptors, they will bind with 9,6 retinoic acid and all trans retinoic acid. So the dimerization of the receptors is going to activate a chromatin, thereby there is a mRNA formation, and mRNA increases the protein synthesis, and that protein synthesis changes the physiological function of the cell, especially like it control expression of keratin gene in most of the epithelial cell. And also retinol, alcohol form of vitamin A, it is involved in glycoprotein synthesis. So retinol, alcohol form and aldehyde form of vitamin A, it is involved in reproduction process. So and carotenoids, beta carotene, it is having an antioxidant function, and also retinoic acid is involved in synthesis of proteoglycans. So one more time, so this is just a collection of all the functions of vitamin A here. So it is retinoic acid, it is involved in gene expression, cell growth and differentiation. Alcohol form is involved in glycoprotein synthesis. Retinol and retinaldehyde form is involved in reproduction process, and carotenoids are involved in antioxidant function, and retinoic acid is involved in synthesis of proteoglycans. Coming to causes of vitamin A deficiency. Now the vitamin A deficiency can be divided into primary vitamin A deficiency and secondary vitamin A deficiency. Primary vitamin A deficiency is because of dietary deficient intake of vitamin A, and the secondary vitamin A deficiency is secondary to something else, secondary to some other disorders. It can be lipid malabsorption disorders like cystic fibrosis, biliary insufficiency, or it can be A beta lipoproteinemia, failure to synthesize chylomicrons, and VLDL happens in the A beta lipoproteinemia. Know that chylomicrons and VLDLs are necessary for the transport of vitamin A from the intestine to the liver, liver to the other tissues. In liver diseases, it can lead to impaired storage of vitamin A and also impaired synthesis of vitamin A binding proteins like retinol binding protein in the liver. All of them can put a person under risk of vitamin A deficiency. Now, what are the deficiency manifestations of vitamin A? So, vitamin A deficiency manifestation is especially seen with different tissues, but mainly it starts in the eyes and also in the skin. So, vitamin A deficiency is endemic wherever diets are chronically poor, like Southern Asia, Sub-Saharan Africa, Latin America, West Pacific, China, where vitamin A deficiency leads to a condition called as xerophthalmia. How this starts? So, initially vitamin A deficiency, it leads to loss of sensitivity to green light. That's how it starts. Loss of sensitivity to green light, and then there will be increased dark adaptation time. What is dark adaptation time? Increase in dark adaptation time means when a person is exposed to the dim light. So, when the rhodopsin is basically rhodopsin which is bleached into meta-rhodopsin and then eventually into all-trans retinaldehyde, that all-trans retinaldehyde converted back into 11-cis retinaldehyde and it has to combine with opsin to regenerate rhodopsin to make the vision possible again. So, that regeneration of rhodopsin, it takes time and that leads to increased dark adaptation time. That means it takes more than normal time for a person with vitamin A deficiency to adapt himself or herself to the dim light or the dark area. And later what happens, after that increase in dark adaptation time, eventually it leads to night blindness, and then later on it can give rise to xerophthalmia. That means dryness in the conjunctiva. That is what is called as xerophthalmia, and also increased keratinization of epithelium over the sclera. It will give rise to a feature called Bitot spots, and these are some of the eye features related to vitamin A deficiency. And also later on, as the epithelial tissue is affected here, so maintenance of cellular epithelium, especially the corneal epithelium and conjunctival epithelium, when it is defective because of retinoic acid deficiency, it can also lead to softening of the cornea, which is called as keratomalacia. And this cornea can actually lead to damage. Corneal can break open, corneal ulceration can happen, and this ulcer can be healed by fibrosis leading to corneal scarring. And remember, cornea is a transparent tissue. It is allowing light to pass through. So, as you see here in the figure here, so cornea is now, it is because of the corneal scarring, so light do not pass through the cornea and it is not going to the lens, so vision decreases in that particular eye. If it happens in one eye, so it can lead to a partial deficiency in the vision, as you see in the figure here. And if it happens on the both eyes, so it can lead to blindness, depending on how much is the cornea that is scarred here. Now, other than vision process being affected, so it is also, vitamin A also affects skin, because proliferation of the skin cells, amount of keratin material that has to be synthesized, the keratinization process, it is altered in vitamin A deficiency, and that can give rise to what is called as follicular hyperkeratosis. As you see here in this particular figure, so skin feels like rough. If you touch a skin of a vitamin A deficient patient, it is so rough, it is you feel it like a toad skin or the frog skin. So, where there will be bumps with the hyperkeratinized epithelial tissue. That's one of the findings that you see in vitamin A deficiency, which is referred as follicular hyperkeratosis. Sometimes it is referred as goose flesh appearance. Goose flesh appearance. Okay, other than skin changes, patients with vitamin A deficiency can also manifest with repeated diarrhea, dysentery, viral infections like measles, respiratory diseases, and also there will be compromise in the barrier and innate immunity. So this acquired immune defenses to infection is decreased, and patients may show like in males testicular degeneration in males can be seen, and increased incidence of miscarriages or malformed offsprings can be seen in females, and also there can be failure of bone remodeling process. So there are so many other functions to vitamin A, not only related to vision process. It is vitamin A is also necessary for maintenance of cell growth and differentiation. It is also important for maintenance of like normal skin. The amount of keratin that is present over the skin has to be controlled. That is done by retinoic acid. And also vitamin A, especially the retinoic acid form of vitamin A, is involved in innate and cell mediated immune mechanism, thereby protection against bacterial infection and viral infection, so thereby preventing against diarrhea, dysentery, measles, respiratory infections. So these are some other functions of vitamin A other than the vision. So collectively, if you look at all these signs and symptoms, should be able to diagnose vitamin A deficiency. Look for loss of sensitivity to green light, increased dark adaptation time, night blindness, xerophthalmia, Wittert spots, keratomalacia, corneal scarring, follicular hyperkeratosis, where there is a like a goose flesh appearance or a frog skin appearance, and testicular degeneration, miscarriages, and malformed offspring, and also failure of bone remodeling process. Now let's move to therapeutic uses of vitamin A. How this vitamin A is used in the treatment of certain disorders. Vitamin A is prescribed for acne vulgaris, Darier's disease, and ichthyosis. All these are the disorders of skin proliferation. And note that retinoic acid form of vitamin A, it controls cell growth and differentiation. That's how it helps in treatment of these diseases. It is also used as a prophylaxis against acute respiratory infections and reduce morbidity and mortality from the respiratory complications. So vitamin A at any stages can be used to treat xerophthalmia, and any stages of xerophthalmia should be treated with 60 mg of vitamin A in oily solution, and usually it is contained in a soft gel capsule, and the same dose is repeated 1 and 14 days later. Now the retinoic acid is useful in the treatment of a disease called promyelocytic leukemia, because it is going to repress cell proliferation, thereby it controls leukemia. Retinoic acid is also used in the treatment of cystic acne, because retinoic acid it is going to inhibit keratinization process, decreases sebaceous secretion, and possibly it alters the inflammatory reaction. That's why retinoic acid is used in the treatment of cystic acne. And also RXR, that is retinoic acid receptor X receptor agonists, RXR agonists are used in they are used in the treatment of diabetes mellitus, because RXR X receptor induces insulin sensitivity in experimentally at least, because RXR is a cofactor for peroxisome proliferator activated receptor. Let me write it down. RXR is a cofactor for PPAR, that is peroxisome proliferator activated receptors, and which are targets for drugs like thiazolidinediones, example rosiglitazone, troglitazone. These are thiazolidinedione group of drugs which are basically acting through PPAR receptors. So that's about vitamin A deficiency and therapeutic uses of vitamin A. Now let's move on to see vitamin A toxicity. It is virtually impossible to ingest toxic amounts of vitamin A from normal foods unless one eats polar bear liver. Take a note of this polar bear liver, because polar bear liver, it contains 6,000 retinol equivalents per gram. And most instances of vitamin A toxicities are caused by massive doses of vitamin A supplements also. So vitamin A toxicity can be divided into acute toxicity, and this is generally seen in Arctic explorers who ate polar bear liver, or it can be seen after administration of vitamin A around 150 milligram in adults or 100 milligram in children. And patients with acute toxicity manifest with increased intracranial pressure. Make sure you remember that part. Increased intracranial pressure is one of the important signs that you see in vitamin A toxicity. And then vertigo, that is imbalance, diplopia, like double vision, bulging of frontanels in children, seizures, exfoliative dermatitis, and sometimes acute vitamin A toxicity can lead to death. Coming to the chronic vitamin A toxicity. Chronic vitamin A toxicity, it is seen in adults who ingest around 15 milligrams of vitamin A per day, or children who ingest 6 milligram of vitamin A over a period of several months. Patients with manifest with dry skin, chelosis, glossitis. Chelosis means cracked lips. Glossitis, that is the tongue inflammation of the tongue, vomiting, alopecia, loss of hair, bone demineralization, bone pain. Patient may have hypercalcemia, lymph node enlargement, hyperlipidemia, hepatosplenomegaly, and importantly, patient will show what is called as pseudotumor cerebri. And this pseudotumor cerebri is because of increased intracranial pressure, and also there can be papilledema. Now, let's move on to see another concept called teratogenicity. See, consumption of isotretinoin form of vitamin A is a teratogenic drug because it is going to disturb the development of embryo or the fetus. And this isotretinoin is used in treatment of severe disfiguring cystic acne. Prolonged use of this isotretinoin, especially in the pregnant women, it leads to a congenital malformation in the developing fetus, and that kind of effects we call it as teratogenic effect. So remember, isotretinoin is a teratogenic drug and it is contraindicated in pregnancy. So that's all about vitamin A. So we have covered the information on vitamin A, especially dietary sources of vitamin A, digestion, absorption, transport to the liver, from the liver how it is transported to all other organs, what are the different types of vitamin A, and what are the functions of each type of vitamin A. Especially we have concentrated on vision process, cell growth and proliferation, and then we have seen deficiency, causes for deficiency, deficiency manifestations, and some of the therapeutic uses of vitamin A, and also the toxic effects of vitamin A. So that's all about vitamin A. Thank you.